In the first presentation this morning, I discussed UIP, nonspecific interstitial pneumonia, and organizing pneumonia. They're the three most common interstitial pneumonias I see in clinical practice. The other two diseases that I see very commonly and commonly get confused with interstitial pneumonias because of presenting symptoms are sarcoid and hypersensitivity pneumonitis, and I will be discussing both of those in this talk. Sarcoid results in the presence of microscopic non-caseating granulomas that occur in clusters, and it's the clusters we can see on CT, not the individual granulomas. Symmetrical lymph node enlargement or calcification also may be seen. 60 to 70% of patients have characteristic plain film findings that can lead you to the diagnosis. 10% or so have normal chest radiographs. And high-res CT is abnormal in most patients with sarcoid who have normal chest radiographs. Usually in that situation, nodules are seen on high-res CT. Lymph node enlargement occasionally seen, but many patients with normal chest films and abnormal HRCTs in sarcoid don't have adenopathy. The high-res CT findings we see include small nodules, which are usually well-marginated, sharply defined, and appear solid. They're not of ground glass opacity. They appear solid on high-res CT. There's an upper lobe predominance in most patients who have sarcoid, and often the abnormalities involve the lung in a patchy fashion. The nodules show a typical perilymphatic distribution, and I will describe for you in some detail what a perilymphatic distribution looks like. And typical lymph node enlargement or calcification is suggestive of the diagnosis in association with the other abnormalities, but is not necessary for diagnosis if you see typical nodular lung disease. Now, this is a demonstration of the distribution of perilymphatic nodules typical of sarcoid. And nodules with this distribution are called perilymphatic because the nodules are occurring in relation to lymphatics wherever there are lymphatics in the lung. And lymphatics occur in specific locations. They are subpleural. So you see subpleural nodules in the periphery and subpleural nodules adjacent to fissures in patients with a perilymphatic pattern. You see nodules in relation to central bronchi and vessels. Lymphatics travel in association with the bronchi and vessels. So peribronchovascular nodules are part of that pattern. And nodules in relation to interlobular septa, which contain lymphatics. Now, because the nodules are occurring specifically in relation to these areas or structures, the overall appearance of nodules that you see when you look at the CT is patchy or non-uniform. Now, this is a very typical CT in a patient who has sarcoid, sort of bad sarcoid, but a nice example. We see nodules in the periphery at the pleural surface and nodules at the pleural surface adjacent to the fissure. Subpleural nodules typical of sarcoid and this pattern. And this is a photograph of the surface of a lung in a patient who has sarcoid, and you can look down through the pleural surface and see these clusters of nodules or clusters of granulomas as these subpleural nodules. Now also notice there are nodules in association with the central bronchi and vessels, peribronchovascular nodules, and this the cut surface of lung in a patient with sarcoid showing clusters of these nodules or granulomas in relation to a central bronchus. So this also a very typical location for nodules in sarcoid. Subpleural and peribronchovascular is a typical perilymphatic distribution, and it's very typical of sarcoid. The differential diagnosis. Well, sarcoid accounts for at least 90% of patients I see with a perilymphatic distribution of nodules. It's a very, very common cause of this. Other causes, silicosis and co-workers pneumoconiosis, lymphangitic spread of carcinoma, lymphoid interstitial pneumonia, one of the interstitial pneumonias I didn't talk about this morning, and amyloid. So there's a sort of a list of uncommon diseases here with exception of, now here's some more examples, perilymphatic nodules in sarcoid, peribronchovascular and subpleural nodules. Those arrows are pointing at nodules in relation to central bronchi and vessels. And here, nodules at the pleural surface adjacent to the fissure. So patchy nodules, peribronchovascular and subpleural, typical perilymphatic, typical of sarcoid. Sarcoid with peribronchovascular and subpleural nodules with an upper lobe predominance. Again, upper lobe predominance is quite typical of sarcoidosis. Centrilobular peribronchovascular nodules may be seen, nodules in a centrilobular location. There are a few examples. I will describe a centrilobular distribution in a few minutes, but centrilobular nodules may occur in sarcoid because bronchi and vessels occur in the centers of lobules, and sarcoid likes to be peribronchovascular, so the nodules may be seen in relation to small vessels and bronchi in the lung periphery. The histology that would be associated with that, a small centrilobular bronchiole, and adjacent to that, a number of these small nodules, small sarcoid granulomas that result in a larger nodule we can see. Now, interlobular septal thickening or interlobular septal nodules are not as common as a finding of sarcoid, but may be seen. These are scans in the lung base in a patient who has sarcoid, and you can see some interlobular septa that show nodular thickening. It's part of a perilymphatic pattern, but not particularly common in this disease. Now, some additional findings may be seen in sarcoid, large nodules or masses in up to a quarter of patients. These are usually bilateral. They are upper lobe predominant because that's where sarcoid is predominant, and parahilar in location. Air bronchograms may be seen in relation to these nodules or masses, and you can often see small nodules or clusters of nodules adjacent to the periphery of these larger masses. Those are called satellite nodules, and that whole constellation of findings with the big mass and the surrounding satellites has been termed the galaxy sign of sarcoidosis. So that's something that can be helpful when you see these large masses. Now, these masses generally represent a confluence of smaller interstitial granulomas. There are just so many peribronchovascular granulomas that they form these larger masses. And then if fibrosis develops, these masses may end up representing fibrous tissue, but early on, they represent confluence of granulomas. This has been termed alveolar sarcoid, but this is a misnomer because all these granulomas that result in these masses and the air bronchograms are actually interstitial in location. Now, ground glass opacity may also be seen in sarcoid. Again, this represents a confluence of small granulomas that simply result in a hazy increase in lung attenuation. And satellite nodules may be seen in relation to these areas of ground glass as well, helping you to make the correct diagnosis. Now, here's a patient with sarcoid and subpleural and peribronchovascular nodules, and some of the nodules, when confluent, form these larger parahilar central masses, and you can see in relation to the periphery of these some satellite nodules, and you could call that the galaxy sign if you wished. Sarcoid, again, with confluent parahilar nodules, some air bronchograms, and then adjacent to the periphery of these masses, you can see satellite nodules, and taken together, again, that is called the galaxy sign. A patient with sarcoid and clustered small nodules resulting in the appearance of ground glass opacity. If you sort of sit back and look at this, it looks like the patient has patchy areas of ground glass, but if you look inside these opacities, you can see the numerous small nodules representing clusters of sarcoid granulomas. And then adjacent to the periphery of these areas of ground glass, you can see individual discrete nodules or satellites that help you decide this is a granulomatous disease and not something like a atypical pneumonia or pulmonary hemorrhage or something of that sort. Now, sarcoid may also be associated with airway abnormalities. These may result in obstruction of large airways. You can have masses of sarcoid granulomas that will obstruct a main or lobar bronchus. You can have small endobronchial granulomas, and small airway obstruction may result from these bronchiolar or airway abnormalities, resulting in mosaic perfusion and or air trapping on expiratory scans. So sarcoid can result in both large airway and small airway abnormalities. Now, here are two examples. On your left is a lung slice in a patient with sarcoid. We're looking at a large bronchus here, and you can see all these little knobby things within the bronchial lumen. Those are clusters of sarcoid granulomas, and these may result in airway obstruction or lobar collapse, something of that sort. Here we're looking at a cross-section of a small airway in the lung periphery, a very small bronchiole, and you can see the wall is abnormally thickened by numerous granulomas. This may cause small airway obstruction, and then secondary to that, mosaic perfusion or air trapping. Now, here a nice example. This is a 45-year-old patient who presented with dyspnea. CT shows a mass within the left hilum obstructing the left upper lobe bronchus. At a lung window setting, you can see that there's significant left upper lobe atelectasis. Notice, however, there are one or two other nodules that are visible in addition to this collapsed lobe, but you would have to consider lung cancer as a likely diagnosis. This is a scan that was as part of the same CT that extended down through the upper abdomen, and you can see a number of low attenuation lesions within the spleen. This has a differential diagnosis, of course, but one of the causes is sarcoid. This is a typical appearance for sarcoid involving the spleen. So in the differential diagnosis of this case, we suggested, well, it could be lung cancer with splenic mets, or it could be lymphoma, or it could be sarcoid. Well, he had a bronchoscopy, and sarcoid was diagnosed. There were endobronchial granulomas that were causing the left upper lobe bronchial obstruction. He was treated for sarcoid, and a year later came back with a CT scan that's more typical of cases of sarcoid we see, with some patchy nodules that are peribronchovascular and subpleural, sort of typical appearance of sarcoid on high-res CT. Here, a patient with sarcoid and small airway obstruction with air trapping, an inspiratory scan in the upper left-hand corner. You can see a few scattered nodules here and there. On the expiratory image in the lower right, you can see marked air trapping involving a number of different lung regions, lobules, and multilobular areas of air trapping. This sarcoid with small airway involvement. But seeing air trapping like this is not uncommon in patients with sarcoid if you do expiratory imaging. Now, later on in patients with sarcoid, as the disease becomes chronic and as fibrosis develops, nodules decrease but often remain visible. Reticulation develops with lung distortion occurring in the regions that showed granulomas or nodules during the active stage of disease. So we tend to see peribronchovascular fibrosis because that is where the granulomas were when the sarcoid was active, usually upper lobe, which is quite unlike idiopathic pulmonary fibrosis and usually allows the two diseases to be distinguished rather easily. But the peribronchovascular fibrosis can result in those same sort of perihilar upper lobe masses. Conglomerate masses of fibrous tissue may result. Traction bronchiectasis is often seen in relation to these masses. And subpleural honeycombing may be seen in a few patients, and on occasion, an individual scan in a patient with sarcoid will look like IPF or UIP, but the distribution is different, upper lobe versus lower lobe. Emphysema and cysts often develop in late-stage disease, and these may lead to the formation of mycetoma. Now, here are a few examples. Sarcoidosis with fibrosis, peribronchovascular reticulation involving the upper lobe. So we are seeing fibrosis here in the peribronchovascular regions, in the upper lobes and mid-lung zones, because this is where the active disease was when the patient had granulomas. And you can see reticulation and distortion of lung parenchyma and a little bit of traction bronchiectasis within the abnormal mass of fibrous tissue. Another example, sarcoid with peribronchovascular conglomerate fibrosis, traction bronchiectasis within those masses of fibrous tissue, and lung distortion. Another example looks much the same, peribronchovascular conglomerate fibrosis, and here on an expiratory image in the same patient, you can see patchy areas of air trapping. Again, air trapping quite common in patients with sarcoid, and the air trapping persists even in patients with late-stage disease. You can develop, or patients with end-stage sarcoid can develop cystic lesions in the upper lobe. Sometimes these represent dilated bronchi, and sometimes they're simply cysts, but this appearance not uncommon in end-stage sarcoid, and because of these, mycetoma is reasonably common in patients who have end-stage sarcoid with lung fibrosis. Okay, the second topic, or second half of this presentation, has to do with hypersensitivity pneumonitis. Now, hypersensitivity pneumonitis is a very common disease. It's caused by inhalation of organic antigens. However, I should emphasize that the responsible antigen is identified in only about half of patients. Even if you have a patient with biopsy-proven hypersensitivity pneumonitis, you send a visiting nurse to the home to search through the home for pets and air ducts and mushrooms and whatever. you can't find the responsible antigen in at least half of cases. Even though you know there's something going on, even though you know the diagnosis, you can't always figure out what the cause is. Hypersensitivity pneumonitis occurs in 3 stages: acute, subacute, and chronic. Usually patients are initially diagnosed, or at least come to initial attention during the subacute phase. They have progressive symptoms over months or years. Repeated exposures to whatever the antigen is produces fever, chills, dry cough, and dyspnea. Now, in the subacute stage, the histology, well, first of all, in the subacute stage, what we typically see are ill-defined centrilobular nodules. 50 to 60% of patients show that. These are usually of ground glass opacity. And the histology sort of predicts the high-res CT findings. These ill-defined centrilobular nodules represent clusters of poorly marginated granulomas that are occurring adjacent to airways as a result of a reaction to the antigen they're inhaling. Patchy ground glass opacity, up to 90% of patients. This is associated with lung infiltration as the process becomes more generalized. Patchy mosaic perfusion or lucent regions due to air trapping may be seen if you do expiratory scans. Air trapping is very common in this disease. This occurs because of the bronchiolitis that is associated with the centrilobular or peribronchovascular granulomas. And if you see a combination of patchy ground glass opacity and lucent regions of mosaic perfusion, which is quite common in this disease, that has been very eloquently termed the Headcheese sign by me. And it's a finding that is very helpful in suggesting the diagnosis, something that's pretty easy to recognize and can lead you quite quickly to the correct diagnosis. I'll show you all about that. Now, this disease tends to be diffuse or predominates in the mid-lung zones. Unlike IPF, it involves the entire cross-section of lung. If you're looking at the CT scan, it does not predominate in the periphery, does not predominate in the central lung. It involves the entire cross-section of the lung you're looking at. No subpleural predominance. Now, centrilobular nodules, typical of this condition in many patients. What do they look like? What is their appearance on CT? Well, these nodules are occurring in relation to the centrilobular bronchiole in this disease, but may also occur in relation to the centrilobular artery, as Paige showed you in patients who had pulmonary veno-occlusive disease. The most peripheral nodules you see when you are dealing with a centrilobular pattern are about 5 millimeters from the pleural surface, because that's where the centers of the most peripheral lobules in the lung are. So nodules with this pattern do not involve the pleural surfaces, as they do with a perilymphatic pattern. They stay away from the pleural surface. And because lobules are all about the same size, these nodules appear evenly spaced if you look at the overall CT scan. Now, here's a nice example: subacute hypersensitivity pneumonitis with centrilobular nodules of ground glass opacity. Notice that the most peripheral nodules are a few millimeters from the pleural surface. The nodules are not arising at the pleural surface. There's a little black line adjacent to the pleural surface where the nodules are not visible. And here at a lower level, the same sort of appearance: centrilobular nodules sparing the pleural surfaces. Notice adjacent to the fissure, you also see that little black line because the nodules are not involving the pleural surfaces. Very typical of a centrilobular pattern and typical of subacute hypersensitivity pneumonitis in many patients. Now, this is histology that would go along with that appearance on high-res CT. What we are seeing here is a centrilobular bronchiole. If I can find my arrow, there it is, the centrilobular bronchiole, and then poorly marginated granulomas in relation to the centrilobular bronchiole that give these centrilobular nodules. Now, the differential diagnosis of centrilobular nodules, well, usually it's going to represent some sort of a bronchiolitis, infectious or inflammatory. It may represent an infection with endobronchial spread. Hypersensitivity pneumonitis, one of the common causes of centrilobular nodules. Endobronchial spread of neoplasm, used to be called bronchiolo-alveolar carcinoma, now is mucinous adenocarcinoma. Pneumoconiosis, silicosis, for example, can give centrilobular nodules because the dust is first deposited there. and then vascular causes, pulmonary edema, pulmonary hemorrhage. But most of the causes of centrilobular nodules are small airway diseases, and one of the common ones is hypersensitivity pneumonitis. Another example of subacute hypersensitivity pneumonitis with poorly defined, ill-defined centrilobular nodules of ground glass opacity, and then also focal lucencies representing Mosaic perfusion due to air trapping. Here another level in the same patient, the poorly marginated, hazy centrilobular nodules of ground glass opacity, very typical of subacute hypersensitivity pneumonitis and something that should be high on your list if you see this appearance. Now here's subacute hypersensitivity pneumonitis with patchy areas of ground glass opacity. That's one of the other common appearances of this. And Mosaic perfusion, I'm just going to define because I'll be talking about it for the next few minutes. Mosaic perfusion represents inhomogeneous lung attenuation, usually geographic, due to differences in lung perfusion. About half the density of lung is blood. If you reduce perfusion to a specific lung region, its attenuation will decrease as well. With vessels appearing relatively large in the dense lung regions, reflecting the difference in perfusion. Airways disease is most frequent as the cause. The low attenuation regions are often lobular in patients with airways disease as a cause of Mosaic perfusion, and air trapping is visible if you use expiratory scans. Vascular obstruction, less common as a cause of Mosaic perfusion. Page showed you a nice example of that in his pulmonary hypertension talk. Now, Mosaic perfusion or air trapping may be an isolated abnormality in several different diseases, bronchiolitis obliterans, asthma, and hypersensitivity pneumonitis. Now, this is an example of Mosaic perfusion here in inspiratory scan. Notice that there are patchy areas of lucency. Here is a single pulmonary lobule that appears lucent, and that is because there is less perfusion of that lobule because of a airway abnormality. And here on the expiratory image, you can see air trapping, and specifically in that one lobule, again, air trapping because of an airway abnormality as the cause of this discrepancy in perfusion. Now, in hypersensitivity pneumonitis, we often see this combination of patchy areas of ground glass opacity and patchy areas of Mosaic perfusion. And this combination together represents the Headcheese sign, and it's very typical of hypersensitivity pneumonitis because hypersensitivity pneumonitis results in both lung infiltration, resulting in the ground glass, and airway obstruction, resulting in the Mosaic perfusion. So that combination is the so-called Headcheese sign. Ground glass opacity equals lung infiltration. Lucencies or Mosaic perfusion equal the bronchiolitis and air trapping that occurs. Now here another nice example of the Headcheese sign in subacute hypersensitivity pneumonitis. And this is why I call it the Headcheese sign. My grandfather came from Germany at the age of 16. Actually, he arrived in the United States on the same day as the San Francisco earthquake. But in any case, he lived nearby and spent time with him in the summer. And he always had head cheese. Now, this is what head cheese looks like. It's made of the chopped and boiled parts of the head of an animal, usually a hog. And this picture I have is from the days before digital cameras. And I went down to the deli and I bought some head cheese and I brought it back and I put it on my flatbed scanner. I don't recommend it, but in any case, when I was done scanning and getting this nice picture, I peeled it off, and I made the second mistake at that point, and I made it into a sandwich and ate it. And it sort of tastes like it looks. But in any case, head cheese has this very geographic appearance with some areas that are sort of white and some areas that are sort of black and some areas in between. And if I morph this head cheese to black and white, I think you can see the similarity in appearance between hypersensitivity pneumonitis and head cheese. And this is why it is called the Headcheese sign, and very, very helpful in recognizing this disease. Here a patient, again, with hypersensitivity pneumonitis and patchy areas of ground glass opacity and areas of Mosaic perfusion, so the Headcheese sign again. And here expiratory images in this patient showing areas of air trapping in those lucent lung regions as we would expect. Here another example of the same thing, ground glass opacity and lobular areas of Mosaic perfusion. Here, air trapping on expiration, as you would expect to see, typical hypersensitivity pneumonitis. Same thing again, 66-year-old bird fancier with progressive dyspnea, subacute hypersensitivity pneumonitis with both ground glass opacity and these lobular lucencies or areas of mosaic perfusion with air trapping on the expiratory images. Now here a patient with an inspiratory scan that looks basically normal to me. I'm not sure I could read this as abnormal. This is biopsy-proven hypersensitivity pneumonitis. The expiratory scan shows air trapping, even though the inspiratory scan didn't show much at all. So this is something you may see on occasion. Now, how about the chronic stage? Patients who have long-term or repeated exposure develop irregular fibrosis consisting of coarse scars and traction bronchiectasis and honeycombing in some patients. The fibrosis is patchy, and unlike idiopathic pulmonary fibrosis, it lacks a subpleural distribution most of the time. It is diffuse or predominant in the mid-lung zones, just like the subacute stages. The fibrosis occurs where the active disease is, and that's usually diffusely, or the mid-lung zones. Again, that's different than the interstitial pneumonias. Upper lobe involvement is quite common, and that would be very atypical for IPF. Superimposed findings of subacute hypersensitivity pneumonitis are present in some patients with fibrosis, so you can see ground glass opacity or centrilobular nodules mixed in with fibrosis. And basically the Headcheese sign with findings of fibrosis is what you might see. So here are a few examples. Hypersensitivity pneumonitis with progression to fibrosis. On your left, you mostly see ground glass opacity with some patchy areas of mosaic perfusion. On your right, you can see fibrosis is developing with some traction bronchiectasis, perhaps even a little honeycombing, but the ground glass opacity is still visible. And notice that the entire cross-section of lung is involved. It's not subpleural predominant. And here we're looking at the upper lobes where the disease is worst. Now here a patient with chronic hypersensitivity pneumonitis, a prone scan through the lung bases shows fibrosis and honeycombing. You might think that's IPF, but the upper lobes show extensive disease, upper lobe predominance, involvement of the entire cross-section of lung, and some areas of mosaic perfusion that lead you to make the diagnosis. Another example, extensive reticulation, but upper lobe predominance. And here a 2D image I showed you in my last presentation showing a mid-lung or mid to upper lung predominance in this disease with relative sparing of the lung bases. Chronic hypersensitivity pneumonitis with reticulation and traction bronchiectasis. Here we see upper lobe predominance. The entire cross-section of lung is involved. There are areas of mosaic perfusion, so this is like the Headcheese sign, but with fibrosis being present. So we're seeing not only fibrosis, but areas of mosaic perfusion and air trapping. Well, in summary, in my last talk, I talked about the interstitial pneumonias. In this talk, sarcoid and hypersensitivity pneumonitis. Taken together, these 5 things constitute most of the cases that I can diagnose correctly or suggest a diagnosis with a high degree of likelihood.